Okay, we can go. Okay. Hello, everybody. Welcome to this webinar organized by the World Association for Bronchology and Interventional Pulmonology. I'm Stefano Gasparini. I'm talking from Italy. I am the chair of the WABIP. Hello, everybody. Welcome to this webinar. Yeah. And the WBAVP, World Association for Bronchology and Interventional Pulmonology, is planning to organizing a series of webinars on the main topics of interventional pulmonology. This is the first one, and this webinar was possible thanks to the support of Pulmonx Corporation that we thank. And more than 400 people are connected because the topic is very important. And probably bronchoscopic lung volume reduction aroused the interest of interventional pulmonology in the last 10 years. You know that when I started to perform bronchoscopy many years ago, emphysema was severe emphysema was a contraindication for bronchoscopy. Now, thanks to development, to the technological development, we are talking about not only the possibility to perform bronchoscopy in patients with severe emphysema, but also to treat and to provide benefit to such patients with bronchoscopy, bronchoscopic technique. So it's a great pleasure for me to introduce the speaker of this topic that is well known by everybody, Dr. Ali Musani. Ali Musani is a professor of medicine and surgery, is director of complex airway pillar of the Center for Lung and Breathing, director of interventional pulmonology program, director of global health pathway internal medicine residency program, Division of Pulmonary Science and Critical Care Medicine in the University of Colorado, Denver, USA. And also, Ali is a member of the Executive Committee of the World Association for Bronchology and Interventional Pulmonology. So it's a great pleasure for me to introduce Ali, that will talk about bronchoscopic lung volume reduction. Everybody can put questions through the chat that you have on the Zoom software. If you have a question, please don't hesitate to write your question on the chat, and at the end of the presentation, Ali will be very happy to reply to all the questions. So thank you very much, Ali. Please.
Thank you, Stefano. Thank you very much, Stefano, for the generous introduction. And you're right. I remember COPD being a contraindication, and now COPD is treated with bronchoscopy. And I'm also very thankful to Pulmonx for sponsoring this program. You know, as some of you know, this is a very critical topic for non-malignant interventions in interventional pulmonology. And it is really one of the most chronic and most debilitating diseases that we face in interventional pulmonology or in pulmonary medicine, which can now be treated with bronchoscopic lung volume reduction. So these are some of my exposures, but none of them are relevant to the topic today. Agenda today is to first briefly talk about COPD, burden of disease, and the treatment options for COPD. and then go into details of bronchoscopic lung volume reduction, how it's done, why it's done, what are the best patient selection criteria for this procedure, and then perhaps equally importantly, what is the evidence so far that supports doing this procedure in severe COPD patients, and then some good evidence that I'll lay out in front of you. And then we'll talk about how different countries, different societies around the world have accepted bronchoscopic lung volume reduction, or BLVR, as a mainstream treatment for severe emphysema. And in the end, briefly, if we have time, we will go quickly through the patient selection and BLVR program development, because some of you may be looking to develop programs or strengthen your programs. So without further ado, let's get into this. So the burden of disease of COPD, as most of you know, that it is the third leading cause of mortality in the US, and perhaps more so in some of the Asian and African and underdeveloped countries, and like in South America, where smoking is still very, very prevalent. And COPD in the US is approximately a $49 billion industry in medical costs. So it's a very big economic burden on the community as well. Emphysema is a form of COPD, which is really one of the most debilitating diseases in terms of quality of life. And the prognosis or quality of life of patients with advanced COPD is at many levels worse than lung cancer patients and stage 4 lung cancer patients. So severe and very severe emphysema represent almost 9.5 to 10% of all the patients that I mentioned, which is 15.7 million COPD patients. So close to 1.5 to 2 million patients in the US have severe emphysema, which would potentially be good candidates for this procedure. And as most of you who are pulmonology or pulmonologists or pulmonology physicians would agree with me that the disease progression is subtle, but very consistent, and with time, the disease is very, very debilitating. It starts with hyperinflation and shortness of breath, and then it goes down to gradually decreased quality of life, decreased exercise tolerance, decreased activity, to the point where people can't even do their day-to-day activities inside the house, and they become almost bedridden or couch-ridden and dependent on oxygen and other supportive therapies, which eventually leads to very high morbidity and mortality. And this is what I was alluding to earlier, that COPD's patients' quality of life has been shown now in this meta-analysis, and in this analysis is worse than people with advanced stage or end-stage lung cancer. But for myriad of reasons, our focus remains on cancer and cancer-related treatments, and we spend way more money on cancer diagnosis and cancer treatment for many reasons, and I don't want to get into it, but if you just look at all the functional parameters here on SF-36 that you use to evaluate patients' quality of life, you will realize that major issues like mental health, social functioning, bodily pain, anxiety, and depression, all of those are better with advanced lung cancer and worse with severe COPD. And one of the key factors that we all need to understand and realize is hyperinflation, which is directly proportional to the mortality and quality of life of the patient. So hyperinflation equals poor quality of life and poor quantity of life. So you will see in this graph that the patients with hyperinflation had much worse quality and much higher death rates or mortality and then the people who did not have hyperinflation. So ICU to TLC ratio was more than 25 in these patients, and less than 25 means much higher TLCs and much higher hyperinflation. And all of these parameters correlate with poor quality of life, poor oxygen, poor BMI, reduced cardiac and circulatory function. So focus has to be on the hyperinflation and treatment of hyperinflation, which we have seen right from our medical school days, that our professors used to put up the x-rays on the boards and say, what is this person has? And people with COPD would have hyperinflated lungs, flat diaphragms, barrel chest, and their lungs popping out of neck, as opposed to the normal lungs. And these patients have very high TLCs and very high RVs and FRCs, as you can see. Now, as far as the different types of emphysemas are concerned, we all know that there are two fundamental types of emphysema. One is the heterogeneous and other is the homogeneous. Very commonly, people seem to think that heterogeneous is much more common, which is opposite of what is the reality. In reality, homogeneous emphysema is much more common and covers about 2/3 of the patient than the heterogeneous emphysema. And treatment options go from left to right, depending on the severity of the disease, and we get to a point where we have almost all of them at play at one point or the other. So inhalers, oxygen therapy, steroid and bronchodilator, and new double and triple inhalers. Pulmonary rehab has been shown to improve quality of life. And then you have options of, excuse me, endobronchial valves, lung volume reduction surgery, and lung transplant. So I guess today we're talking about severe emphysema patients where they've already had optimal therapy with inhalers, and most of them have had pulmonary rehab. Now, what do we do? If they're still symptomatic, is still requiring high oxygen, is still requiring lots of hospitalizations and exacerbations, what do we do? And that's where I would like to focus for the next half an hour or so. And that's exactly what this patient of ours had. So this was a patient who was 66 years old, FEV1 of 27, TLC of 112, so in hyperinflated lungs, DLC of 44, RV of 191, so she had air trapping, RV TLC ratio of 70, 6-minute walk was significantly reduced, 158 meters. We checked her echo to make sure she doesn't have pulmonary hypertension. Her RVSP was 35 to 40. Our cutoff is about 45 for major intervention bronchoscopically. And we looked at the CT scans, and she had pretty okay looking CT for a severe COPD patient, no evidence of bronchiectasis, no lung nodules or masses, or no significant bullous disease. She had quit smoking several months or almost a year ago. And she still, despite all of this, quitting smoking and optimal therapy, she keeps getting exacerbations 3-4 times a year, which requires prednisone, antibiotics, and often hospitalization. And this is her CT scan showing significant emphysema. So as we often do in our advanced emphysema patients, when we are starting to consider them for our meeting, which I will talk about in the end of the discussion, where we discuss our advanced emphysema patients with a group of people, including surgeons and transplant physicians, we do StratX evaluation. So this is the CT analysis, which is done by the company Pulmonx before Zephyr valve placement, when you're starting to consider them for this. And what it does is it divides each lung into the different lobes and gives each lobe a severity score of emphysema based on the damage on the CT scan. So it has to be a high resolution CT with thin cuts and overlaps. and which tells you, and then they do the tissue analysis and tell you how severe the emphysema is. And the dark black is the score when the emphysema is very severe, more than 70%, and then lighter gray is 60 to 70%, and very light gray is 50 to 60. So this is one aspect of StratX where we look at the severity of emphysema. This allows us to figure out what area to target, what area to be avoided because of lack of emphysema or other factors. The second thing that this report gives us is the fissure integrity. And as we will discuss in the next few slides, fissure integrity is extremely critical. And now we go beyond just StratX. We have now new technology to determine if fissures are intact or not. But for the analysis purposes, the integrity is shown as a dark black line if it is 95% intact, 80 to 95, if dark gray if it's 80 to 95% intact, and if it's less than 80%, which is considered pretty poor integrity of the fissures, is dotted line. So in this, you could just look at the image and get a very good, quick idea of the right upper lobe having the most severe emphysema, and then right lower lobe has less severe, left lower lobe has practically minimal emphysema, and left upper lobe has moderate emphysema. As far as the fissure integrity is concerned, the fissure between the right upper and right middle is very poor, so there is a very high chance of collateral ventilation. And this is dark gray, which is probably between 80 to 95%, so there is a decent chance it may not be as bad, and we would need to confirm it before we perform the procedure. We don't reject patients based on this. On the left side, it is the emphysema scores are poor in the lower and moderate in the upper, and then fissure is very poor. If the difference between the severity of emphysema is more than 10, we consider that as a heterogeneous emphysema. Otherwise, if it's less than 10, we consider them as a homogeneous emphysema. And these are the numbers as I was just describing. So you can look at right upper lobe emphysema score at 72%, which is the most severe. And again, the color coordination here helps you determine quickly, and then fissures the same way. And at the bottom, they give you the volumes. So if you were to decide to take out right upper lobe, obviously you will have to take it out with right middle because the fissure is not intact. So if you were to take out right upper and right middle, you will be taking out about 1,780 cc's and leaving behind about 896 cc's. So all of these calculations go into the decision making. So BLVR has been a part of a whole slew of procedures which basically came into being for bronchoscopic lung volume reduction, and we'll talk about that briefly too. So in heterogeneous patients, we have two types of valves, Zephyr valves and aspiration valves, but for all practical purposes, most of us use Zephyr valves now. And it will become very obvious as we go through the presentation that why we prefer Zephyr valve. One of the predominant reasons is that we have a collateral ventilation assessment tool, which allows us to have much higher success rate by using that tool, and that's part of the Zephyr procedure. The other thing is homogeneous emphysema has been shown in studies to improve with Zephyr valves. Aspiration doesn't have any studies showing that so far. And then upper and lower lobe emphysema, both valves work. And then fissure integrity, Zephyr valves require 80 to 100%, while aspiration valves ask for about 90 to 100%. So these are the different approaches that started out 15, 18 years ago, when all people around the world were thinking about this technique of causing airway obstruction, basically airway obstruction bronchoscopically rather than surgically removing a lobe. And they use plugs and blockers and sealants and valves and coils for heterogeneous. And for homogeneous, there was a study called airway bypass surgery. And then it was from Bronchos Technology, and a big study called Exhale was carried out, and bronchial valve for Zephyr. So you will realize Zephyr valve is the only technology that's good for both heterogeneous and homogeneous. For homogeneous, airway bypass basically failed, and it was not recommended for use anywhere, actually. And then most of the heterogeneous modalities, such as plugs and blockers and sealant and biologics, they have not really panned out very well, and not being used very much. Coils have been used a little bit, but it's still not approved in the US. The only modality approved in the US are valves, both Zephyr and aspiration. So this is how the valves work. You do a flexible bronchoscopy, usually under general anesthesia, not almost always under general anesthesia, and you go to the pre-selected lobes, which you have selected based on CTs and statics evaluation. And the valve is loaded into a catheter, and catheter deploys the valve in the pre-selected, predetermined airways. And I will show you more videos of how we measure valve sizes for different airways and where we place the valves and what happens if there's a problem. But the bottom line is, once the valves are placed, air cannot go into those lobes, but the trapped air can come out slowly, and secretions can come out, which prevent the post-obstructive secretions. And also, once the air starts to come out with time, we start to see atelectasis. Sometimes that atelectasis is very fast and happens within hours or even sooner, and sometimes it takes weeks. A lot of studies were done, starting right from early 2010s or so. And in the last, or actually NET trial was 2001, which was a surgical lung volume reduction. And that provided the framework for all of other studies for bronchoscopic lung volume reduction, since once we learned the physiological aspects of that surgery and how it works, the only sort of a limitation after that was how to achieve that. You could achieve it surgically by removing it, or you could bronchoscopically block the airways that are going to the bad part of the lung. So the studies started in getting published in 2010, but I know studies were going on even years and years before that. And in the last decade or so, there are myriad of studies with Zephyr valve. Zephyr has been very, very productive in terms of clinical trials, and most of these trials are prospective, randomized, international double-blind trials. And most of them have used the system called Chartis system that we will talk in a few minutes, which helps you determine fissure integrity and collateral ventilation. And a big part of the success of this procedure, ever since the earliest first trial with Chartis system, Stelvio, established, is due to this. It gives you the confidence that you're not putting valves in an area where there will be collateral ventilation, and your outcomes are much better. So I will talk about some of these studies in the future slides, and we'll go over the studies in detail. And now, what is the concept of collateral ventilation? I know most of you know very well, but fissures, if they are not intact, like here, the air can go through the collateral channels from one lobe to the other. So if you block the airway going to, for instance, left upper lobe here, and you would think that, okay, now there's no air going in, so the lobe should collapse. But if there are collateral channels, because of the very damaged fissure, which often happens in emphysema patients, that lobe will never collapse completely or even partially, because air will keep going in and out of the lobe through the backdoor channels. If you determine that fissure is intact, then no air will go in and out. And once you block it, once you block the main pathway of air entering to that lobe, you will see that the lobe will collapse. And it is very crucial for the success of this procedure. And as I mentioned earlier, besides looking at the integrity of the fissure on the StratX analysis, CT analysis, we also perform Chartist balloon evaluation. And how this is done is we go into the airway and we inflate a balloon with the flexible bronchoscope before we do even the measurements of valves, let alone putting the valves in. And the center of this catheter is center of this device in the balloon is a catheter which takes all the air coming out of that and it goes into the machine, and machine plots a graph of how much air is coming out, and it gives you an enormous detail of how much air is coming out, how much air is left, how much air flow is going on, and it plots multiple graphs to give you an idea. So sorry for the background noise, and this is the Chartist balloon evaluation for one of our patients. So this is the air coming out, tells you the time here, how many seconds have gone, and then how much flow is there, what is the peak flow, how VT20, how much air has come out in volume. And this number is supposed to consistently go down. And you can see that, now this is a cumulative graph. This is every second, but this is cumulative graph. And you start to see this cumulative graph going down with time, showing that the amount of air coming out of the lobe is going down because there's a finite amount of air and there's no more air coming in through the back doors. So it's going down, and now you've got VT20 about 11% or 11, and peak flow is going down as well. Total volume is going down as well. And the amount of air coming out, we can calculate and see. So now we have been doing this for a minute, and close to a minute and a half or so, the volume has gone down very significantly. And this is actually a picture of graph how it looks, and you're going to start seeing the same thing here. We're getting to about 6-second mark, which is what, sorry about Maddie's voice in the background. She's getting all the balloons and catheters ready. Once she sees this trend, she starts getting everything ready. And then we are almost at the point where the flow has gone down significantly low, 1.5, almost 2 seconds, and flows now. VT20 is below 6. To get to below 6 or 6, we basically have no air left, and there's no volume. So this is how we do it in every single case. Well, that was very noisy. So let me show you some of the sentinel trials and publications that basically established Zephyr as a dominant technology for treating emphysema bronchoscopically. This is a Liberate trial. It was a multi-center, randomized, prospective, multinational study with 24 sites and 2-to-1 randomization. So it was sham control study. Primary outcomes were post-bronchodilator FEV1 improvement of 15% at 12 months. So as opposed to earlier studies where we were just looking at 6-month mark, this was 12 months. And then secondary endpoint was FEV1, post-bronchodilator FEV1, 6-minute walk distance, and St. George Respiratory Questionnaire. So what I've done is I've put up graphs rather than the lot of wordy details. So if you look at the FEV1 at 45 days, so baseline 45 days, 6 months, and 12 months. So the blue are the people who got the BLVR, and yellow are the sham control or controls. You can see the FEV1 goes up high pretty quickly, and then at about 45 days, it is at its peak, and it is 15% improvement. And even after 1 year, even with all the expected deterioration in patients with COPD, you're still 10% above the people who did not get BLVR. Similarly, RV, which is, again, hyperinflation is a big reason why patients feel bad during COPD, when you have COPD or COPD flare-ups. So RV and TLC goes down. That is one of the predominant features why patients feel good. So here we see RV going down more than 600 cc's and staying still very close to 500 or between 500 and 600 cc's even after 1 year. St. George's questionnaire, 4-point decrease is considered as statistically and clinically significant. These patients went down up to 10, and even after a year, they were up to 8. So very substantial improvement in the quality of life based on St. George's questionnaire. 6-minute walk also improved. 6-minute walk in some patient was sort of a pretty impressive criteria or analysis, because these patients, once they started feeling better, they started developing their stamina, more exercise, and some of them really did very, very well. So again, this is the responders graph at 12 months. People who got BLVR are blue, and people who did not get BLVR or the controls were yellow. You can see almost 60% of the patients had FEV1 increase, more than 12%. And BOD index improved in almost 60% of the patients. 6-minute walk improved in 40% of the patients, and total lung volume reduction happened in 84% of the patients. So most of the parameters which determine quality of life and overall way patients feel and exercise and tolerate day-to-day activities improved. This is, again, similar to what we just discussed, patient-reported outcomes of Liberate trial. Again, multiple measures of life were taken into account, and these are the patients who are dark blue are the patients who had Zephyr valve placement, and the light blue are the controls or standard of care patients. So again, as you can see, 6-minute walk and other parameters improved very significantly. This is daily diary that patients keep when they have severe emphysema, and the study they did. And patients who had Zephyr valves, these are plotted at the bottom, and standard of care were up here. And this is the total symptoms diary over the 12 months period. So it started from day 0 and went on till day 1 year, 52 weeks. So you can see that their overall symptoms, quality of life based on symptoms intensity, was much better. Symptoms intensity was much lower, including all the COPD exacerbations, cough, shortness of breath, wheezing, as opposed to patients who did not have Zephyr valves and who were treated with the standard of care with all their medical therapies. Now, what are the complications of these procedures, and what are the sort of untoward effects? In this study, one of the which has the highest pneumothorax rate. So pneumothorax was the most pertinent quote unquote complication of this procedure. However, I have always contended that we should probably not call this as a complication. We should call this an expected event that would happen in a certain patient population. And it's not unexpected. We pretty much have a very good sense of why it happens, in which patients it will happen, and we are very prepared to deal with it. So it is, I always contend that complication may not be the right word to use. Many surgeries, patients come out of their surgeries. Chest surgeries almost always come out with chest tubes. It's not considered complication of surgery. It is part and parcel of the procedure. Any case, in the first 45 days, complications included death, pneumothorax, COPD exacerbation, respiratory failure, and pneumonia. So 26% of the patients had pneumothoraces in this trial. And in the latter part, after 46 days to 12 months, another maybe 6% developed, 6.6% developed pneumothorax. 4 patients died in this, and 1 patient died in the latter part of the year. And then some patients had COPD exacerbations, pneumonia, and respiratory failure. So as always, these studies were a very good learning experience for us to tackle these issues. And I'll tell you how we have tackled these in the latter studies and now in the clinical arena. This is a graph that shows you that most of the pneumothoraces happened in the first 3 to 4 days. So day 1, day 0, and day 3. So in these 4 days, most of the pneumothoraces happened. And how they were treated, the dark blue is chest tube, the lighter blue is, the lighter blue is chest tube only, the dark blue on the top is chest tube plus valve removal, and the lighter blue is observation only. So you can see that first day when this happened, again, we were at the learning curve of our technology. Valves were removed in a significant number of patients and chest tube was placed, but as the day passed, we got more and more comfortable with just putting a chest tube or observing some patients. And then pneumothorax happened much less in the following weeks to months. And I'm sorry, and this is exactly why we keep patients in the hospital for the first few days. This is the other study called Stelvio. This was the first trial which used the Chartis system and showed the importance of Chartis system. If the patients were CV negative, then they got these valves and had very improved significant lung function improvement, exercise capacity, and quality of life. And you can see FEV1 improving in patients who got EBV or endobronchial valves, 6-minute walk improving significantly, and SGRQ improving significantly. And then the minimum clinically important difference also, significantly improved. If you look at SGQRQ, it is several times than the requirement, and then 6-minute walk and the crossover EBV groups. IMPACT trial was very significant because it took all the homogeneous emphysema patients, so 92 subjects, randomized trial with Zephyr valves versus the standard of care, and intention to treat. Primary endpoint was FEV1 of 15% at 3 months. And so even in homogeneous emphysema, the study showed that 13.7% of the patients who received about 13.7% improvement in FEV1 was noticed at 3 months. And then all the other parameters of primary and secondary endpoints remained statistically and clinically significant at 6 months period. So this is 6-minute walk in patients who got the valves and patients who did not get the valves. Similarly, FEV1 and MMRC scores, SGQRQ, and RV. Transform trial was 97 patients with severe heterogeneous emphysema, and they had both CT evidence of intact fissures and Chartis evaluation for CV negative. Again, this was a randomized study, 2-to-1 randomization, and with Zephyr valves and standard of care. And again, we followed these patients for 6 months, and the key point here was the confirmation of efficacy across primary and secondary outcome measures in heterogeneous emphysema when you use Chartis and CT both. And the study shows, as we alluded to earlier, that 6-minute walk improved statistically significantly. FEV1 improved and it stayed up for 6 months. Similarly, SGQRQ and other parameters. So, in summary of these studies, when patients are CV negative, based on the Chartis balloon evaluation and other evaluations, the outcomes are significantly improved. And all these studies, Liberate, which was published in Blue Journal, Transform, Blue Journal, Impact as well, and Estelvio was published in New England Journal. They were all prospective, randomized, sometimes 2-to-1, and other times 1-to-1 randomized studies. Significantly larger studies, especially the Liberate, which was the largest trial, and showed significant success in FEV1, exercise capacity, and quality of life. So as I mentioned earlier, -4 points is considered statistically or minimum clinically important difference. But most of the studies here showed a lot more than -4. Here it's -14 actually. So as a result of all these evidences that I have just presented of international prospective randomized trials and clinical success of this technology, now these valves, Zephyr valves, are approved and are being now put into the guidelines for the advanced treatment of advanced emphysema. They're part of the GOLD guidelines, which is the Global Initiative of Chronic Obstructive Lung Disease, as an evidence level A. They're part of the UK's National Institute's guidelines, German Respiratory Society guidelines, and Netherlands guideline. And so nationally and internationally, very well recognized, well established, and proven system for the treatment of severe emphysema. More than 25,000 people have been treated around the world with this technology. So I'll briefly, I don't know how much, we still have about 20 minutes, 19 minutes. So in the next 5-6 minutes, I'm going to quickly go through what our program is and one of our patients, what we did with our patient that I mentioned earlier. So we have an advanced emphysema or emphysema advanced therapy called EAT program at the University of Colorado, Denver. We established it several years ago when valves were approved in the US by FDA. The purpose of this program was to bring every patient through this board or committee, and the members of the board or committee were lung transplant physicians, lung transplant surgeons, CT surgeons who do LVRS, and COPD emphysema doctors and interventional pulmonologists. And we discuss every case to see their eligibility for different treatment options. So some patients may be deemed suitable for lung volume reduction with valves, but not with surgery, or deemed suitable for transplantation and lung volume reduction, bronchoscopic lung volume reduction. And then we discuss and plan and say, okay, let's do the BLVR first and see how we can buy some more time and improve patients' quality of life while they're waiting for the lung transplant. And after the discussion, we do the procedures. Every patient goes through that. And we have a very protocolized, standardized management. We have 2 pages of guidelines. Every patient, when it's is admitted, it goes to the residents and fellows. We always keep patients in the step-down unit. There is a pneumothorax kit always with the patient. As soon as patient comes out of the operating room, it stays there on their bedside. And we keep our patients in an area where there's a 24/7 coverage by the doctors. So if there's a pneumothorax, they can come in and place the chest tube easily. In many hospitals, that's not the case, and they're doing just fine too. But this is, since we are at university, we have lots of fellows and residents, we have a luxury of doing that. So this is what we did with our patient. We put the lady that I mentioned earlier, we go in, and this is a live case. We measure with just single catheter insertion, we can determine the size of the valves. There are 2 sizes, 4 and 5, and they come in 2 lengths. One is regular, another is low profile. So depending on the runway that you have to place the valve, if it's very short, you place a low profile, but it's still the same diameter. And then this is our patient who we placed valves. You can see it's pretty old. So we have catheter in, we already know what size valve we're going to place. It's loaded, and we line the green line by the carina, and we deploy the valve. So the valve is now deployed, and we'll go back and see how it looks before we go out completely to, here we go. We go in and we see that valve is looking good. And then we go and see the valve again, and you can see the valve is already literally breathing. As soon as the patient inhales, valve shuts down, prevents any air from going in. And when patient exhales, the valve opens up, allows all the trapped air to come out. And this is exactly what the whole mechanism is, to slowly prevent air from going in and cause atelectasis of the lung, of the lobe. So this was our patient that I mentioned earlier. This is pre-procedure, severe COPD, as I mentioned, flat diaphragms, large lung volumes, hyperinflation, air trapping. This is immediately after the procedure. You can see we did the BLVR in the right lung, that the left diaphragm is still flat, right diaphragm is slowly coming up. You can see that, and lung is starting to come down. And if you pay attention to the right paratracheal strip here, there was nothing here first. Now you can see the upper lobe is undergoing atelectasis. After 5 days before discharging the patient, you can see the atelectasis has settled in really nicely. Diaphragm is up. Now compare left lung to the right lung. Here, the diaphragm were almost same level. See that? Look at the overall volume of the right lung compared to left lung now. And you can see the trachea being shifted to the right, means the right upper lobe has undergone atelectasis. And even after a whole month, you can see the nice dome of the diaphragm is still very effective at atelectasis, is still some deviation of the trachea. Now, you will see that this is much impressive than day 30th. It's not because atelectasis has resolved or something has gone wrong. It's because the lower lobe now has hyperexpanded and taken up some of the space, which is exactly what we want. We want the healthier lung to participate more in the ventilation perfusion, and we want the defected lung to collapse and get out of the equation. So this patient, PFTs before BLVR and 1 month later, FEV1 went from 27 to 47, TLC went from 112 to 113, DLCO improved significantly. Look at the RV, and most importantly, look at the 6-minute walk, which is most important to the patient. How far they can walk and do activities. 156 meters to 240 meters. She could walk within few weeks of the procedure almost 90 meters more, which is a lot of walking for a severe COPD patient who is oxygen dependent. So how do you select patients, or how do you tell your colleagues who to send to you? Basic steps. Make sure patient has emphysema and asthmatic component is taken care of. We don't exclude patients who have both asthmatic component and COPD. As long as asthmatic component is not the predominant phenotype, and as long as it is treated optimally, because a lot of people have an overlapped syndrome. They're not actively smoking, and if they are, they're willing to quit. FEV1 is below 50, and they are short of breath, and MRC is more than 2 or equal to 2 after optimal therapy. These are the very basic criteria for looking at patients. Once you have that, then you start looking at smaller, less sort of intricate details, that BMI is not very high, they are not taking too much prednisone, they are non-smokers, and then 6-minute walk is 100 to 500 meters. You check FEV1, you check RV should be more than 150 for homogeneous and 175 for heterogeneous. TLC should be more than 100. You should get a CT scan, do the StratX evaluation. Perfusion scan is highly recommended for just about everybody. We used to do it on only homogeneous patients, but now we do it in everybody. Make sure they don't have major PCO2 retention, and then they don't have a severe cardiac problem or pulmonary hypertension. So these are all the detailed things that you screen patients with, and then you place the valves or you send patients to the center. Often people would just do the first page that I showed you for major selection, and then you send them over to us for detailed processing and detailed analysis of the patient. So in summary, Zephyr valves have been extensively studied, as I alluded and showed multiple studies to you in a very robust studies. They have been clinically shown to be very significant in improving patients' quality of life. They have been now approved and recommended by almost all the major societies, pulmonary societies around the world, including US. And Zephyr valves are now covered by insurances, most of the insurance companies in the US. And severe emphysema patients, as you know, are looking for treatments because a vast majority of these patients don't qualify for lung transplantation. And surgical lung volume reduction hasn't been very successful. Even after decades of net trial in the entire country of US, there aren't even a couple hundred patients who undergo lung volume reduction surgery. So between these two options, there aren't very many patients who are eligible. So bronchoscopic lung volume reduction offers them a wonderful option. Well, I'll stop here and I will open it up to any questions you might have. Stefano, you can let me know what the questions are, please. And I
Thank you very much, Ali. Wonderful presentation, very complete. I look at the chat. At this moment, there are no questions. Please, if you have a question, write it on the chat, and Ali will be very happy to reply.
I actually see a question. Question is, if we don't achieve atelectasis,
Four questions. Just I see 4 questions.
Okay, I can go through the first question. The question is, if we don't achieve atelectasis but achieve an improvement in reduction in RV and status post and some improvement, do we consider that a success? Also, is there any ongoing trial for EBVL placement with patients with incomplete fissure in terms of reducing air trapping and breathing? So it's multiple questions in a question. Number one, we don't, if patient has significant reduction in RV and TLC and they have clinical improvement, then we still leave the valves in as long as they have improvement. And we determine that at a later point whether if there's no benefit to the patient, then only we remove the valves. The second part of the question is there is a trial, I think, one was published or is in publication from actually the principal investigator and author is from Italy, who is studying the patients with incomplete fissures as to how to finish or complete the fissures before doing the procedure. I can't tell you too much because I'm not sure if pulmonics people want me to tell anything more about that procedure. I hope I answered your question. Next question is from, so this question was from Taha Hassan. And the next question is from Dr. Tucker. Can you help explain the pathophysiology of why pneumothoraces improve after valve removal? Also, what are your thoughts on different protocols to help minimize pneumothoraces post-valve placement? Example is strict bed rest for 24 hours, a stage procedure, etc. Removal of. So, number one, pneumothoraces happen for myriad of reasons. People have scarred pleura, people have previous infections and inflammations, their pleura is damaged and tacked up to the chest wall. They have small bullets, which become significant after the BLVR into the remaining lung. So lots of reasons why people develop pneumothoraces. And we have pretty well-established protocols for managing these patients. So if patients are symptomatic or pneumothoraces are very big, we place pigtail catheters in them, either ourselves or IR. Most of the time we end up putting it. And then we monitor these patients closely. If they continue to have the pneumothoraces and bronchopleural fistula or leakage after a certain time, usually a week to 10 days, we start thinking about other options, and the next options are to remove valves. Different people have different strategies. Most of the people try to remove either one or two valves to allow some re-expansion of that lobe, and that often also allows some time for healing and pneumothoraces get better. If that doesn't get better, then we start looking at surgical options, removing all the valves, and then surgical options such as pleurodesis. We often do, actually, we almost always do CT scans to make sure patients don't have large bullous, and which were not apparent before the valve placement, because the lobe that has now hyperexpanded after atelectasis of the target lobe may have bullous enlarged in that lobe that is left behind, and that may also be contributing to pneumothorax. So there is we actually, if we just recently wrote about all these potential complications and how to manage them in the World Association of Bronchology's newsletter, which was just published last week. Jerry Kreiner and lots of other people wrote very detailed account of how to manage these complications and how to deal with all the problems. Actually, my fellow and I wrote 3 or 2 major complications and how to handle them. But the short answer is we should be ready for these complications, and we have a protocolized approach for treating them, from removing valves to surgical options. I hope I answered your question. There's another question. I don't know.
There are a lot of questions, Ali, a lot of questions.
So we have about 5 minutes, so I'll go ahead and answer another question if that's okay with you, Stefano.
Yes, I would like to underline 2 main points that you showed us. The first one is how is important the selection of the patient for this treatment. In my experience, I see that people send patients that are not hyperinflated, that have other diseases of infection. What about the presence of bronchiectasis, for instance? Is a contraindication, or the presence of infection is a contraindication for such kind of treatment? What do you think about?
Yeah, significant bronchiectasis, which leads to significant sputum production, is a contraindication. So we literally have a criteria. If patients are coughing up more than 4 tablespoons of phlegm every day, sputum, then we consider them as a pretty active bronchiectatic patients. Even with mild to moderate bronchiectasis, we try not to block those airways, because then they can grow infection and we will never know, and the secretions may not clear very well. So bronchiectasis is a consideration for and a contraindication, but it's a relative contraindication. With mild bronchiectasis, which is common in COPD, patients have no sputum, no phlegm, they have never had a flare-up. It's doable. We can do it. We try to avoid that lobe if possible.
Yes. There is another question that, in my opinion, is interesting. Is it possible to remove the device at a later time after it's been placed?
Yes. Short answer is yes. I've never, except once, which was more than 7-8 years ago, where I had very significant difficulty in removing the valve, and they were not even the Zephyr valves. I've never had a severe difficulty removing Zephyr valves after even months and months. So Zephyr valves are easily removable. And then one of the questions I was just reading was, can the patients go for transplant after valve placement? Yes, this is a very good question. Patients, ideally, any patient who is waiting for lung transplant and is a good candidate for you for valve placement should be a good candidate, because it will buy them more time and improve their quality of life. And it's not a contraindication for lung transplantation. So one of our patients just literally last week had a transplantation, and I had placed valves in that patient more than a year ago. So it's doable and it's done all the time. Go ahead.
Yes, in my experience, what do you think about? In my experience, if valves works and there is atelectasis, generally valves are not source of infection in the future. If valves doesn't work and there is no atelectasis, valves could be easily source of infection. And in our experience, if valves doesn't work, we remove it after 3 months, 2, 3 months. What is your opinion about?
So I agree that valves are usually not the source of infections. I have rarely ever seen patients having post-obstructive pneumonias after valve placement. I think partly because just like valves, they are one-way valves. They allow air and secretions to come out. So these are not the problem. And what was the second part of your question? I'm sorry, Stefan. I was trying to read some questions here.
If valves doesn't work.
Yeah, so if they don't work, after, let's say, a month or 6 weeks, patients are still not feeling better or feeling worse. That can happen. Then we have to consider removing the valves. I usually do evaluation, not Chartis, I mean the Stratix evaluation again. And I do CT scan again, and I repeat PFTs. If they show no improvement in PFTs or worsening of PFTs, sometimes you can see those things too. And if you see CT scan showing the valves have displaced, which is rare but possible, and if you see statics showing that there is no significant improvement after the valve placement, and most significantly, patient symptoms are not improved, then you should consider removing the valves to bring patient back to their baseline. I had a patient who had actually worsening of his FEV1, worsening of his DLCO, and no improvement in any other parameters. And after 5 weeks or so, or 6 weeks, we removed the valves because sometimes what happens is, especially when we don't do ventilation perfusion scans in patients, we can block off some of the lobes, which are significantly important in the ventilation perfusion of the patient. But with our PFTs and CT analysis, we didn't realize it very well. So that's another critical point that I now do VQ scan in everybody. So you will realize that patients where they have who had deterioration in their symptoms after valve placement are usually the patients who had very good perfusion in those lobes. So you have to look at the VQ and make sure that the lobes that you're going to block have the least perfusion, highest damage on CT and Stratix, but least perfusion on the perfusion scan. And then you block that. So we used to do it only in homogeneous emphysema, but now even in heterogeneous emphysema, we do VQ scans to make sure we don't get into this trouble.
Okay, I think that the time is finished. Thank you very much, Ali. Wonderful presentation. I know that there are a lot of questions more, and probably if you want, you can write an email to Ali, and I'm sure that he will reply to all the questions that you want to do. Thank you very much to Pulmonx for making possible this webinar. And I promise you that in the next month, other webinars will be organized by the World Association for Bronchology and Interventional Pulmonology on different topics of our wonderful specialty. Thank you, everybody, for listening. Thank you, Ali. Thank you again to Pulmonx. Thank you to Michael Mendoza that take the organization of this webinar. And have a good, I don't know, in Italy is a good night, a good day in Asia, and good evening in USA, everybody. Bye-bye. Thank you very much.
Appreciate it. Thank you.